Good evening, everyone, and welcome to the Arthritis in the Military, Getting the Best Possible Care. We are so happy to have you here. My name is Erica D'Agostino, and I am the Senior Executive Director for New England. Tonight's experts will share important facts for you about arthritis and everything you need to know on tips and how to advocate for yourself when it comes to getting the care you need. Just a few quick housekeeping notes for tonight's event. We have muted all the event's attendees for tonight, but you can ask direct questions that you have throughout tonight's presentation in the Q&A box at the bottom of your screen. We will have time at the end of the presentation to take all of your questions, and the panelists will handle them, so no need to worry about that. After tonight's session, you will receive an email asking about your experience, and these surveys are really helpful for us to help track the success of these sessions and better plan for future events, so please take time to fill them out. So without any further ado, let's get started by introducing our guest moderator, Commissioner Rob Santiago. Commissioner Rob Santiago joined the City of Boston in 2016 as the Deputy Commissioner at the Mayor's Office of Veteran Services. He is the first Puerto Rican and LGBTQ Veteran Services Commissioner in the city's history. Before joining the Mayor's Office of Veteran Services, Commissioner Santiago served 20 years in the Navy in diverse duty stations, including sea duty on 4 warships and overseas tours in Belgium, Puerto Rico, Panama, and Japan. He retired from military service in 2008 while on board the USS Constitution. Commissioner Santiago is on the executive board of the Massachusetts Veteran Services Officers Association and is a lifetime member of the Veterans of Foreign Wars and the American Legion. He is also a member of the leadership team for the Homes of the Brave initiative, which is part of the Mayor's Challenge to End Veterans Homelessness, and the newest member of the Arthritis Foundation's Massachusetts Local Leadership Board. Rob, welcome, and thank you for joining us tonight.
Thank you, Erica. Thank you for that introduction. I want to welcome everyone. We are so thrilled to have you here tonight joining us for the second annual Arthritis in the Military Roundtable webinar. I seem to be having, okay. Hold on a second. I'm having issues with my laptop here. Can everybody see me?
We can see you.
Okay. All right. The City of Boston Veterans Department is thrilled to once again be partnering with the Arthritis Foundation on this one-of-a-kind educational roundtable. This night is particularly special because in partnering with the Arthritis Foundation, we have been able to connect service members and veterans with subject matter experts in arthritis from across the Northeast. We have also been able to bring together the Arthritis Foundation with veteran services officers throughout the Commonwealth. And tonight is a great opportunity to go even further and discuss how arthritis threatens one of every 3 veterans and service members. Arthritis in the military is a silent enemy. We know that 1 of every 3 veterans and service members in the United States live with arthritis. This starts in basic training, where new recruits carry packs up to 100 pounds that injure and weaken their joints, which often leads to arthritis. Rigorous training regimens and deployments put them at higher risk for osteoarthritis. Also, service members are often found to have arthritis within 2 years as a result of combat injuries. This proves that arthritis is prevalent in veterans and active duty service members. I myself, I've never considered that while serving our country that I could also be destroying my joints and not even knowing it. So tonight, I'm very excited to hear from our panel of experts on what we as veterans and active duty service members can do and what treatments are available to us. First, we have Dr. Jessica Orth. Dr. Orth is an Army physical therapist currently serving as the Director of Human Performance Operations in a Special Missions Unit within the U.S. Army Special Operations Command at Fort Bragg, North Carolina. She has 17 years of service and deployed numerous times in support of both Operation Iraqi Freedom and Operation Inherent Resolve. Dr. Orth is a certified orthopedic clinical specialist and holds a variety of certifications in both human performance and orthopedic manual physical therapy. And she also currently holds the rank of Lieutenant Colonel in the United States Army. Next, we have Dr. Matthew Liang. Dr. Liang is a physician specializing in rheumatology. He is a professor of medicine at Harvard Medical School and a professor of health policy and management at the Harvard School of Public Health. At the Brigham and Women's Hospital, he is medical director of rehabilitation services, and Dr. Liang served in the United States Army Medical Corps and is also the study director in the Veterans Administration Cooperative Studies Program, where I myself had the pleasure of working with him for many years in the VA Boston healthcare system before leaving to join the city of Boston in my current position. Next, we have Arthur Madure. Arthur Madure is a licensed massage therapist with offices at the Caritas Carney Hospital. He has over 25 years experience in medical settings, primarily treating patients with difficult chronic pain and dysfunction. He is also nationally certified in therapeutic massage and also nationally certified in bodywork with advanced certification in neuromuscular therapy and integrative movement therapy. And as you could see, this is a great panel for us to have here tonight. 3 out of the 4 of us have actually served in the military and are current veterans. So let's get started. Dr. Liang, let's start with you. What are the most significant challenges military members with arthritis face?
Oh, big question. I think the most important one is probably seeking help. In our clinic, we see relatively few patients compared to the patients that we know have arthritis and arthritis-related conditions. And over the time that I've been in the VA, which has just been the last decade or so, I think that the system has underappreciated how much of a problem it is. And in Boston, we're in Vision 1, and Boston is a referral center. I would say that it's been historically a unit of part-time physicians. And other places in New England only have a rheumatologist as a consultant, usually someone locally that serves as a consultant. So I think for a lot of different reasons, arthritis hasn't been on the map in the VA healthcare system. And when it has been, we feel like we're just seeing a fraction of the patients who are suffering from it. And I don't know whether it's because veterans don't complain, and they may assume that having painful joints is part of being in the service or just part of life. But for us, arthritis is possibly 100 different disorders, some of which are life-threatening. Others are very common. Everyone has them, like low back pain and shoulder pain. And then the ones that we would assume would be much, much more prevalent in the military population would be people who have various forms of degenerative arthritis. These could be from trauma. It could be from normal aging. It could have been at the point when they actually entered the service. So I think that the recognition of the problem has been systemically a problem. And for people who have served who are getting VA care, they may not even be at a point where they complain about it, or their primary care physician referring them on for more detailed evaluation if they're not being managed successfully. I'm sorry for that long-winded answer, but it's a big, big problem.
Jessica, Arthur, you have anything to add? Any thoughts on that?
Yeah, I would say that I would agree. And I think a lot of physicians will prescribe and physician assistant nurse practitioners will prescribe medications, right? Oral medications, pain medications, because the primary complaint is pain. And, I'm here to represent the physical therapy community tonight. So we'll talk a little bit more about that. But I think access to care from a primary care perspective, but then access to those supplemental therapies is also a challenge, sometimes even to get through our own system. So I agree.
I also want to bring up a point that Matt brought up about the veterans not really asking for help or not complaining about any situations that they may have with pains. And that goes back again to like what I mentioned earlier to the days in boot camp. A lot of veterans don't want to say that they're hurting or they're in pain because it may affect the jobs that they are actually trained for in the military. So they'll live with that pain, and eventually it'll go with them when they finally leave service and become veterans. And it's not noted in their military service jacket or in their medical service jacket that they had these pains. A lot of that is due because they're afraid that they may miss a promotion, or that if they're a master at arms, for example, or base police, that they may end up, going to a desk job as opposed to doing what they were trained for. So that's a very, very good point, and I just wanted to say that. So with that, with these challenges that we just discussed, what are some tips that we could help veterans and service members get in the door and get the care that they need? Jessica, you could start with this one if you'd like.
Sure, I'd love to start with that one. So for most folks, your primary care provider, whoever that may be, is your first entry point and touch point for treating any of your painful conditions. And so starting there, I think, is super important, just from a continuity perspective and getting the right referrals. And then advocating for yourself in that referral. I think knowing what questions to ask, i.e., may I see a physical therapist for my pain? May I see an acupuncturist, massage therapist, different providers. I think in that moment, there is plenty of opportunity for the veteran to advocate for themselves. And I highly recommend that, as supplemental therapies are often so much better than any type of medications, and will lead to a much better quality of life. So being your own advocate for those alternative therapies in that moment, I think, is important.
So how can our military members best prepare for their appointments to get that care?
Actually, could I just back up a second? Bob,
Sure.
I'm going to interrupt. I just wanted to also emphasize that arthritis just means pain in the joint. For us, it's just an entry point of evaluating someone, and we're trying to sort them out in a variety of ways and put them in groups where we can manage them effectively. And some of these are things that you need to diagnose right away because they can be life-threatening. So I think that if people can learn what I call the red flags, and we are often educating primary care physicians and people who see persons at the first instance, what some of these danger signals are of things that need to be sorted early, referred early to someone who knows about them. So, and I'm sure that everyone on the panel can weigh in, but I think any symptom, and this includes other bodily symptoms, where the symptoms don't go away after a couple of weeks of self-care or time, you should worry, or if they're getting worse during that period of time. If it's something that prevents critical function, this might be as a breadwinner or a vital function for your job. Obviously, it may not be as urgent medically, but from a social point of view, it's critical in terms of keeping someone in the game. And the other group of arthritis disorders that always worry us are people who have arthritis plus something else, particularly what we call systemic or constitutional symptoms. That's like weight loss, unintended, fatigue, fever, unexplained rash. All of those things on top of an arthritis condition can suggest a more serious or treatable illness, or that the arthritis is just a manifestation of what we call a systemic illness that really needs to be sorted out early. And some of these are almost like code for a triage person at the first instance. And I think that lay people should have as much knowledge about those things too, to sort them and advocate for themselves, as Dr. Orth has pointed out. I'm sorry for interrupting.
Oh, no, Matt, this is a roundtable. You could speak whenever you like, sir. So you mentioned advocacy, and I know Jessica also mentioned advocacy. So can you give us any advocacy tips for our veterans and service members while they are in the doctor's office? Anyone can start.
Uh, I'm a patient now, and I can tell you that it's always better to have an advocate with you, especially in a hospital nowadays, but even in an outpatient, because most of us who go to a doctor's or a nurse's office are a little gun shy. We're probably in denial, even doctors, especially doctors. And there's so much anxiety, you tend to forget what's being asked or remember what's being suggested. And I think having another person there, and they don't have to be an expert, to just ask questions. There are no dumb questions, just dumb answers, is just critical in terms of keeping people honest and communicating. And so I'm a big fan of bringing in someone else into the office and taking notes, asking questions, then and in follow up. And there isn't anything that is brought up that isn't worthy of clarification.
Those are great points, Pat. Very great points. Anyone else have anything to add?
Yeah, so I'll usually tell folks, and this is more for my folks getting ready to go for their retirement physicals or things of that nature. That's usually where I have this conversation, but I think it's applicable here, is to prepare for that appointment and keep a notebook by your office, whether that be an actual office or in the restroom where you maybe spend a little time. And every time you think of something or think of a question, write it down, because then oftentimes in a doctor's appointment, things are expedited and you feel rushed and like you don't have time to ask the question, or like Dr. Liang said, you might forget, right? Because it feels very like an anxious situation and you might be rushed out of the office. So I find that keeping a question, keeping a log, or just a sheet of paper that you've thought about and prepared for before the appointment can also help facilitate conversation and Q&A.
I think that's
Oh, Dr. Liang, you're muted.
nearsighted. I think that's a great suggestion about journaling before and after, because the chronology of when things occur is so critical to our understanding and sorting out. The other thing which we teach novice clinicians is that before they discharge a person from their office, they should just put just some key words down in writing. And that has been shown in a variety of studies to improve understanding and compliance with the recommendations. And I think it doesn't take a lot, but these are all aids to actually listening and communicating.
I have a question. When you see these patients and you feel like maybe they're not asking the right questions, or maybe they're not giving you the responses that you think you may need, do you ask any leading questions? You try to do any investigatory words or maybe comments to try to get down to the bottom of why they're there?
I absolutely do. I think that's the part of the the process of an evaluation, right? And a subjective and objective evaluation of your patient. And so, yeah, oftentimes as a provider, I'll definitely ask some leading questions. How long has this been going on? What sort of things exacerbate it? And then if they're not quite understanding what I'm getting at, yeah, I'll definitely dig a little bit deeper. Not necessarily in an attempt to walk the patient into what I believe the diagnosis is, but for me to better understand really how it impacts their life. And like Dr. Liang said, the chronology of that illness or problem will help us diagnose that and treat that better, for sure.
Arthur, how about you? Do you talk to your patients and try to figure out what they're doing, or what get down to the bottom of it?
Oh, absolutely. I wanted to bring out one thing, though. A lot of my patients are medically referred, being in a hospital setting. And one of the frequent things they'll say is, well, nobody ever told me about alternative therapies. I was given the option of medication or physical therapy or surgery or more investigation, MRI. And that is the main referral pattern. So I'm opening that up a little bit, and this is what people have to do for themselves. They have to look into alternatives. Nowadays, acupuncture is getting a lot of notoriety for pain. I know the VA, the Brigham, Boston VA reached out to me and credentialed me as a massage therapist in the Boston VA. And there was an effort to expand alternative services. So my point is simply that it may be the few options that you're given may be fine, but if they're not fine, I think it's incumbent on the patient to open it up. And just because a doctor or nurse practitioner doesn't suggest it, that doesn't mean they're against it. It probably means that they just don't know enough about it. And that's changing. I know one of the great things I see in a note is that a referring doctor will say, I offered them the option of physical therapy or the Osher Center, which means alternative therapy. The Osher Center is a branch of the Brigham. So little by little, we're getting to be in the treatment picture. So I hope to present that as a viable option.
Thank you, Arthur. And that's a great leeway into our next topic, which we're going to talk a little bit about treatment options. But first, I want to ask, what are the most common types of arthritis that military members and veterans experience? Jessica?
Well, I think for me, it's probably osteoarthritis, right, or traumatic arthritis. Those are the two most common that we see. Chosen profession, those unfortunately are the side effects of the chosen profession of arms. So that's short answer, but it's short and sweet. That's what it is.
Matt, how about yourself?
I think, I'm unmuted. I think we need more information because of the underreporting that we all suspect, but I would agree that these are likely to be exaggerated, I shouldn't say exaggerated, heightened numbers of the common and probably the most important public health forms of arthritis that we face in the general population. And that's in the large category of osteoarthritis. And for us medically, that means almost a consideration joint by joint. The treatment is joint by joint. And it includes all of our tricks, because none of the things that we have really change the natural history. But I think we can certainly improve function and diminish symptoms. And if worse comes to worse, some of these joints are amenable to replacement, but not all. And so that's the largest group. But it's also, unfortunately, the group that formally train rheumatologists have the least amount of training in, because they are usually in departments that are more concerned with systemic inflammatory causes of arthritis. So I think that as I was learning my art, I learned more from my wife, a physical therapist then, and the people who emphasized the physical exam, rehabilitation, manual approaches. And these are not actually part of a regular diet for medical students, despite the fact that it's so important. And our experience in Boston too was that even in the schools of physical therapy, the teaching of musculoskeletal problems was also inadequate completely compared to the importance of the problem and how many people are affected by it.
Thank you, Matt. So that leads me to the next question. Now, it was mentioned that osteoarthritis and traumatic osteoarthritis are two of the main types so far that we've seen. But going to Matt's point, there still needs to be a lot of research because of the underreporting. But for now, what are the best treatment options for these types of arthritis? And this question is for all three. Our author, starting with you.
Well, People don't come into me with, say, I have osteoarthritis. They come in, I have low back pain, I have shoulder pain, I have knee pain. Um, um, I usually have access to their medical record so I can see whether they have a diagnosis of osteoarthritis, but I treat their presentation. And so osteoarthritis is in the background, and I have so many different ways of assessing them. The first gateway is, well, what's been done before, and usually as an alternative therapist, what I do and my skill set has never been tried before. So obviously, if you try a certain route, even if it was massage in the past and it didn't work, well, what type of massage? So in my role of different types of therapies, my goal is to find out what's been done, what's worked, what hasn't worked, and weave that with my skill set of, light touch, deep touch, mind body work to find something that hasn't been done. It's that old thing. If you keep doing the same thing, expecting a different result, that's the definition of insanity. So you have to think a new thought, have a new approach, and that's the alternative direction that I'm promoting. Most people get a lot of relief through traditional care, and my perspective is more for people who don't.
Thank you, Arthur. Matt, how about yourself?
Well, I try to make another diagnosis just to make sure that I don't get trapped, because osteoarthritis is seen radiographically by X-ray in almost everybody over a certain age. And a lot of these are age related and they're not really the cause of the symptom. So I try to make another diagnosis, and particularly by joint, look for soft tissue lesions that might either be the cause of the pain or a component. And as I said, because we don't have any biologic way thus far of changing the natural history of some of these things, I'm looking for things that I can treat more specifically that can afford comfort and improve function. Some of these might include mechanical factors like um, people with hip or groin symptoms that you could also see an X-ray suggestive of osteoarthritis may actually have a trochanteric bursitis. And if they have a bursitis, I'm usually thinking about a mechanical cause for the bursitis. I mean, and so I'm looking for leg length discrepancy, joints above and below that might be putting unusual stress. Uh, I'm looking for symptoms that aren't usually improved almost completely by not loading the joint, which makes me think about other uh, aspects around joints that can cause symptoms. And then medically, there is no magic cure. And I try to do everything possible to avoid regular treatment, especially with nowadays opioids. If you're using opioids, and I think that you're not really getting the best holistic management, because opioids are such a danger in of themselves. And I think in the past, patients with symptoms have been made into different kinds of patients, addictive patients, because of indiscriminate use of painkillers without understanding why that person is suffering or having symptoms.
So, Jessica, I have anything to add for that question before?
I think we'll probably get to more of that. I mean, I agree with everything, and in a minute I'll probably talk a little bit more about PT and what PT can offer, which is touching on a lot of these points. So
Yeah. So with Matt, with what you said, are pain medications generally prescribed to manage this pain?
I can't speak for the totality of patients, but I think that, as I said, the background training of most physicians, thoughtful, well-meaning otherwise, is that they basically treat the symptoms once they make the diagnosis. And they don't really get into the subtleties that I'm talking about that I've learned the hard way, but also because you learn these things on the job more than you do from your medical school training or your house staff training. And I think that, I would do everything before I would put someone on regular treatment, especially just for pain. Uh, you know, and there are reasons to start just simple Tylenol, acetaminophen, and I often use an anti-inflammatory, which has a little different spectrum of side effects and possibility of adverse effects. If I get a sense that there's an inflammatory component, either by examination of a joint that I can palpate, or I have evidence that there's inflammation, and sometimes that begins with hearing that the symptoms are worse after prolonged inactivity and get better with use. We call it gelling or AM stiffness. These are these little things that I ask to prescribe because there's no blood test for osteoarthritis. And X-rays, as I said, are X-rays don't cry, and almost everyone over the age of 50 can have X-ray changes that might suggest that they have osteoarthritis, but that isn't a diagnosis by itself.
Thank you, Matt. So, Jessica, I think this is what you're waiting for. So besides the medication, what are some of the complementary therapies to help manage arthritis?
Yeah, great. So I'd also like to put in a plug for Arthur. I think, multidisciplinary approach is never, we're talking about things kind of compartmentalization here, like PT, alternative therapies, like they're separate. I think it's super important to at least make the statement that a lot of these things work better even in conjunction with one another. And by no means, if one has not worked, you should not try the other. I think more is better, quite honestly. And we have an acupuncturist we use and a massage therapist we use as well in conjunction with PT. So I'm definitely not PT will solve everything. I think a multi-D approach is the best way. I think it's important to talk a little bit about physical therapy just as a profession. I think a lot of people have a misperception that physical therapy is primarily for post-operative patients, right? People who have had surgeries and trying to get them back walking and moving again and being functional in their life. But myself as a orthopedic and sports medicine PT, and then working in the military special operations setting specifically, my job is to keep people moving and keep people healthy. And so PT's big jam is evaluating mobility, strength, stability, and those soft tissue factors, like Dr. Liang mentioned, that can cause pain, right? Because I always say, I'm not Yoda, so I can't really fix that osteoarthritis, but I can sure do a lot for all that soft tissue stuff around there. And so imbalance in any of these musculature feeding into a joint can actually put tensile forces across the joint that are a big producer of pain. So I've had plenty of people come with a diagnosis of osteoarthritis, but they're so immobile or so inflexible that their joint doesn't even have space to move. So if we can just give them space to move with soft tissue techniques or other stretching or manual therapies, dry needling, things of that nature, they often do quite well. And so I think understanding that PT is not just for post-operative patients and that you can ask for any source of pain and we can do a lot to help that.
You mentioned about physical therapists. What are some of the qualities to look for in a physical therapist?
Yeah, sure. So fit is super important. There are lots of flavors of therapists and lots of different specialties within therapy, right? So I always give the example of just because I went to PT school doesn't mean you want me doing physical therapy on your child. I am not a pediatric therapist. So if you brought me your child, I would have the first clue how to evaluate or treat them properly. So doing some research in your local area, knowing what clinics treat what type of patients. And you can often tell by looking at their website or even going to visit the clinic. Sometimes you can get a good vibe there. But if you are a 30-year-old athlete, right, you're probably not going to want to go to your total joint replacement geriatric clinic, right? Because that's really what they specialize in is back to life and back to movement, vice sport or more orthopedic-based PT. So I think knowing that there are different types of physical therapists out there and researching therapists in therapy clinics in your area. Asking for a referral source by name with your provider is oftentimes a great way to get where you want to go. And then kind of on the right side of that, if you go to PT and you're just not feeling it, right? Like if the clinic is not what you're looking for, you're not, clicking with your therapist, I would ask for a new referral to a different location, and that's okay. I've had plenty of patients that I was just not the right provider for them. That happens. And so please don't turn your nose away from PT or any other types of therapies if you're not clicking with a certain provider or a certain clinic because it just doesn't meet your needs. So I think knowing that there are different varieties and different offerings within the PT subspecialty is an important thing.
Thank you, Jessica. Arthur, what would you like to add to non-drug therapies and complementary treatments?
But one thing, an unfortunate thing, most alternative therapies are not covered by insurance, with the exception of workers' comp and motor vehicle accidents, which are covered. Secondly, you can bypass that for those veterans out there who say, gee, I'd love to have my craniosacral therapy or some other therapy that they have found effective covered. And a practical solution is to find a physical therapist or an OT, an occupational therapist, who is covered by insurance, but has the skill set of doing alternative therapy. So that's one avenue. Sometimes that's not, you can't find that person in a clinic because, and Jessica, you can elaborate on that. I find clinics have a little bit of a set repertoire that they do. And if you are a craniosacral therapist or a Feldenkrais practitioner, you have to go out on your own, but you can still bill insurance, at least in our area. So those are some additional factors as far as resources for veterans. If you want to expand the field, but you don't want to pay for each visit, you can try to find somebody within the system, PT, OT. I think that's pretty much what's covered in the medical system. Acupuncture is covered by some types of Medicare. Chiropractic is covered by Medicare in Massachusetts. So that's one little tip. If you're still not satisfied, you just can't find anybody, you might have to bite the bullet and just find the best person, regardless of whether it's covered by insurance. Most of the people that come to me are not covered by insurance. And I don't go to anybody but chiropractors that are covered by insurance. So anything that I do is fee for service, and I have no problems paying for it because I value being healthy.
Yeah. In Vision One, we often use the people in rehab, the physiatrist, and closely related are the geriatricians that have a very strong clinical unit. And actually I'm on the advisory board of the GREC in Boston, and the head is actually a physical medicine person. And it's like, it's the difference between talking to someone about a paradigm or a way of treatment that they don't really understand or do. But it's a lot different to get when you talk to them because they understand what you're looking for and often can individualize it. And that's all within the VA. But again, I think all of us have emphasized the fact that you just have to hang in there. And if you're not getting better or getting worse, you have a right to get better. And I think that it can be available in certain locales, but you have to find the pathway sometimes yourself, unfortunately. Can I just give you an anecdote? Because I think that one of the most important things that I've learned as a physician is that it takes a while for a person, to gain the trust and have trust in their provider. And I remember a woman that I inherited from another physician at the Brigham who had chronic neck pain. And I saw her for like 2 to 3 years. And every one of my progress notes was identical. She came in, told me that she had neck pain. I would do my exam and not really find anything specific. And she carried the diagnosis of, degenerative cervical spinal disease. And then one day, after the same carbon copy visit, as she was going out the door, she closed the door and said, could she ask me a question? And it turned out that was the time that it took for her to gain trust in me, that I would take her symptoms seriously and try to do something. And I found out at that point that her son had physically tried to strangle her. And it just completely made sense to me why her pain hadn't gone away. But it was the emotional, social factors that, when something doesn't really make sense, there might be some underlying suffering that's often emotional or mental health issues. And I think that in our clinic at JP, I would say that I don't see everybody, but when I brought in to review a patient, I would think that more than 2/3 have PTSD. And, a lot of the ones that I see are doing well, but there are others that are still actively being treated. And I think that wars leave scars, physical, emotional. They don't go away, even though a person may appear that they've healed. And I think that's always a consideration. And again, it's a holistic effort to address those in a meaningful and effective way. And I think that we're all advocates for multidisciplinary, persistent efforts to help people suffering, whether it's physical plus mental health, et cetera.
Matt, you brought up a very good point about the total pain plus the stress that comes, and plus also the stress that comes with serving can greatly impact mental health. We are going to have a great partnership between the Arthritis Foundation and Boston Veteran Services. We're going to have a separate webinar on this topic in the future. And we, of course, invite you to be a part of that panel as well. In the meantime, if someone is listening tonight and is struggling, what are some resources that they can seek for support? Anyone could start.
Well, I gave Erica a list of find a therapist directions. If you're interested in at least a starting point for alternative therapies, whether it's massage therapy or myofascial release, people who specialize in, they do this all day long, you can find them. And Erica, are you listening?
I am. I'm here, and we will share those.
Okay, so I just wanted to point out that most certifying bodies have a some sort of a find a therapist. So if you're looking for a craniosacral therapist, and I'll be glad to answer the question of what that is. But if you're looking for a craniosacral therapist or a Feldenkrais practitioner or a neuromuscular therapist or a trigger point therapist, you can look at their certifying bodies, like the Upledger Institute certifies craniosacral therapist, and Feldenkrais Institute for Feldenkrais, and the American Massage Therapy Association for an umbrella of manual therapies. So that just expands your view as far as how you go about doing it. And it's just a starting point. So if you got on the site and you say you like the idea of finding somebody with specialized skills and you want it covered, just look for somebody who's also in the PT/OT field, and you may get it covered through your insurance.
Yeah, the same is true if you go to the American Physical Therapy Association website. They have a whole section there on find a therapist, but also under the physical therapy specialties tab on their website, you can find a specialist in orthopedics and things of that nature, or the American Academy of Orthopedic manual therapists. They also have a great website where you can find manual therapists in your area.
I would just step back a little bit, and for someone who's suffering, I would say get a diagnosis first. And the way that that happens technically in the VA is that you could call the helpline. I've actually tried to do that myself, and I have some comments about that. But the other thing is that most veterans are assigned to a primary care doc. And I think it's completely appropriate for, if you're not happy with the results, to ask for a referral. In Boston VA, some of these syndromes that we're talking about have a drop down for the PCP to say that before you send them to us, do the following, just to make sure that the database is adequate and the tests that you can do that are useful are done. And then, as the colonel said, get your act together and try to write out the narrative, sketch out the narrative, and, a good person reviewing your case should be looking at your electronic medical record and looking at the other things that you have been followed for to make sure that those are not factors, either for expanding the possibilities for diagnosis, but also limiting the kind of treatments you have. And then you should be in an office of a specialist. That varies depending on where you are, I think, physically. And that's, I think, a systemic issue that the commissioner, I'm sure, is aware of, that not every place has the full group of potential specialists or experts who could weigh in. But the VA has got a system of moving people around within the system. I've ridden that. It's a really interesting exercise of listening, but it is available in the VA system, which is not true in the civilian system. So there are multiple avenues, and I think that you should be able to at least initiate some of these, and also to be as diligent and as forthright about whether you're making gains or not.
Thank you, Matt. All great thoughts.
Yeah.
So tonight we've covered a lot. We have a lot of questions for the Q&A portion of it. But if there's one piece of advice each of you would like to give our audience to take away from tonight in 1 minute or less, what would it be? Jessica, would you like to start?
I think the best advice I can give you is be your best own advocate, right? We're, your doctors, your primary care doctors, your PTs, all of us in here on the panel, we've got plenty of schooling, but we're not living in your skin and living your life. And so if you're not getting to the bottom of it, if you're not getting the answers you want, if you're not satisfied with your care, I wouldn't just take that and store that. I would advocate for yourself. And if that means going to a patient advocate at the VA, if that means asking for a new primary care manager, whatever that means, you're in charge of your own healthcare. And so take charge and advocate for yourself. That would be my advice.
Thank you. Great advice. Arthur?
Yeah, I would like to reiterate what Dr. Liang said, that there's a certain amount of patience involved. And what Jessica said, that you need to be your own advocate. And from my experience in dealing with people and dealing in a integrative clinical setting, these are all solvable problems. Osteoarthritis and knee pain There are many, many non-surgical, non-drug ways. And I know in my experience, that's the very first thing I try to rekindle in people is the fact that they can change, that they can be hopeful again. The body is a growing entity. It's changing. It's trying to heal every day. And so my message is a message of optimism. I don't care how long you've had pain. I've had people with pain for years and years and years. And, you know, just something that wasn't tried and bam, they're out of pain. So not saying that I'm the solution for everybody, but I'm sure every therapist says, gee, nobody tried this. I tried it and they're out of pain. Or they couldn't walk, they can walk. So that's my message. You know, where there's life, there's hope. And there's so many possible ways of treating the pain dysfunction from osteoarthritis or any other orthopedic condition.
Thank you, Arthur. And you say you might not be the solution, but you're definitely an alternative that we could all look into. Matt?
Oh, I hate following these two. Anyway, I love taking care of veterans. And one of the things I've learned is that, you know, first of all, this is the largest healthcare system in our country, cradle to grave. They can't fire you if you aren't getting results or you're spending the VA's money. And the VA, the veterans are the most powerful political group in the country. And you've spoken about individuals with arthritis, but I think the systemic issues, veterans cross the aisle because they are doing it for their brothers and sisters and they're doing the right thing. And I hope that they not only, as you mentioned, advocate for themselves and have hope, but they also make it better for the people that follow and others in the system. And I know they will, but
Thank you, Matt. I want to thank everyone for attending tonight and to our great, wonderful panel of speakers for educating us on the impacts arthritis has on our service members and veterans and how to combat it. But before we start the Q&A, I do have one shameful plug that I want to make. As we all know, there were in a historic move towards comprehensive healthcare for veterans, the PACT Act, or the Promise to Address Comprehensive Toxins, was signed into law by President Biden. The PACT Act extends VA healthcare and benefits for veterans exposed to burn pits and other toxic substances, and also for contaminated water in Camp Lejeune for many, many years. So here in the city of Boston, we're going to be hosting and honoring our PACT Act webinar next week, September 15th at 6 p.m. It'll be pretty much the same format as we had here tonight, along with a Q&A session at the end. We will be discussing the key points of the act, the VA healthcare benefits, both on the benefit side as well as the healthcare side, and the do's and don'ts of filing for the claim. So all attendees tonight are welcome to register. I'll throw in the link in the chat. So if anybody would like to join us, please come and join us. So at this time, I am turning it over back to Erica D'Agostino for the Q&A portion. Erica?
Hi, thank you, Rob. Thank you to all the panelists. Oh, Rob, don't go anywhere because you have to be here for the Q&A too. You're not off the hook. Thank you everyone for attending. We're super excited. We've been inundated and bombarded by your incredibly amazing questions. We certainly aren't going to have time for all of them, but we've tried to gather them into types of questions for the panelists so that we can try to get through as many types of questions as possible. So bear with us. So panelists, here we go. First question, how can we make a better case for having arthritis? I have medical records stating hip pain and inguinal pain, but I am told the VA won't link to arthritis without a nexus letter from a physician saying military service aggravated the condition. I have civilian physicians reluctant to say events from 20 plus years ago contributed to my arthritis is problematic for being a veteran. Actually, this goes to maybe what Jessica was saying earlier about preparing for the discharge interview and things of that nature.
Yeah, I mean, I'll answer that a little bit. I have no experience, full disclosure, on the VA medicine side of the house. So I'm going to speak if there's anyone listening kind of from the active component and getting things service connected and service related. I think that having incidents, right, being able to tie things back to incidents in service is important. Being able, obviously, to document that ideally before you leave service, so then that can get translated into your medical record and thus be related to compensation and VA claim. Yeah, but if that's not in there and you're trying to tie it to service, I think talking to your provider as specific as you can about incidents and why you think this is related to service, because that language and that verbiage is really what helps build that case. Dr. Liang can probably talk a little bit more about the VA side of things, but that is very frustrating and challenging. I know a lot of people are struggling there.
Actually,
You are off muted.
oh, wait a minute. I'm sorry. Can you hear me now?
Yes, you are.
Okay.
You're totally off mute.
And actually, I just wanted to acknowledge I'm not talking for the VA.
We know.
Yeah.
This is
We
your
know.
complete opinion, and my opinion might be a little bit surprising, but I am I do not think service-related assessments are fair. They're demeaning to the individual, and in a way, it's prescribing disability for someone to get what I consider a basic right, which is healthcare. In other words, you have to have disability to get anything that would help you in the way of a social net. And I just think it's inhumane for people who've served to have to make this case. So I can't help you because I think that the whole proposition is a flawed part of not only the VA benefits, but also Social Security. And I've said this as a consultant to the Social Security Administration, that this is just a self-fulfilling prophecy and just perpetuates disability. And it's a waste of our time to be fighting this exercise or doing this exercise when we could be just providing the services and a social net to people who really deserve it, I think. But that's my opinion, and I'm not talking on behalf of any group on that regard.
As a private person and civilian.
Yes, yes.
Rob, did you want to say?
I could say this as commissioner,
Go ahead.
Okay.
but also as a veteran myself. One of the biggest frustrations that we do have in our office, and Matt, you touched on it, is filing VA claims. Because there are a lot of times that a lot of our veterans don't get the services or are denied the services because there's not enough proof or it didn't happen in service.
Yeah.
And sometimes the service perpetuated, but the symptoms came once they got out of the military. So that is very true what Matt said. And it's an ongoing issue with the VA on both sides, the benefit side and the healthcare side, but it's something that we fight for our veterans every day on. And again, if a claim doesn't come back with the percentage that we thought that this veteran should get, then we, of course, will file an appeal and take it from there. But it happens quite a bit.
Okay. Second question, how can a service member change the culture of visiting their PCM? We might come in with a list of questions, but we are definitely rushed out because they are trying to keep to their 30 or 15-minute appointment schedules, which consists of taking vitals and then waiting for the doc to then come in. Usually it's, I would imagine, a 15-minute cycle. I throw that to the whole panel at large. How can they be better empowered to change the dynamic of that power set?
So I'll start, I guess. I think prioritizing the list, right, to the things that are most important to you. To Dr. Liang's point, I mean, our system, and speaking as just Jessica, as a PT, right, our system is broken. I think we all know that, and it's extremely frustrating, especially, and this goes for healthcare across the board, right? You know, the quick appointments and working to a number and all of that. We are a system of dysfunction rather than health. It is frustrating. So knowing that, right, having to work within that system, unfortunately, that's what we're talking about. So creating a prioritized list so the doctor can address the things that are most important to you and most impactful to you, I think is important. And then, you know, trying to take your list, take your questions, and make them as direct and succinct as possible. Versus, you know, it kind of goes against creating like this chronicity or timeline for your injury too, what we said earlier. But if you're limited by time and you feel rushed, kind of have your, I think, kind of have your highlight points in as succinct as possible for the physician, and will help direct them to address those problems in that appointment. And then before you leave, ask for a follow-up. You know, I would say that, hey, all of my issues were not addressed today. I don't feel that we had the time to address that. Can we go ahead and schedule another appointment and a follow-up to address the rest of the issues? And then don't leave until that appointment is made. I think would be a good way to approach that in a broken system.
That's a good idea. I have one other thought on that, because our system at our Osher clinic at the Brigham, and I suspect at all Osher clinics across the country, is as to ask the facility, what is the time on your initial consultation? If you go to our clinic, I believe it's an hour. He sees an hour, and I know this particular doc prepares for an hour before and takes an hour to write up. So that's a particularly nice system because you can read his notes. Mine is an hour and 15 minutes for initial. And, you know, so if you think you need to be heard, you need the time to be heard. I could not do a sufficient, any kind of evaluation, develop rapport, really hear what a person's saying in 15 minutes or a half hour. I mean, people need time and space, and you need to give them your full attention. And then you have to know that you're giving them your full attention and you're not writing your notes and so forth. So that's just another idea. If you have the option of choosing a doc to investigate, well, what's, you know, how much time are they going to give you? And then follow up with Jessica's ideas of being succinct if you're forced into a short visit.
I think that's a great point. Dr. Liang, did you have anything else to add to that?
Well, I was hoping that the commissioner might help, but I know that in our rheumatology clinic at JP, there is no clock. And again, we're not bombarded like many primary care physicians are. And by the way, I don't know if veterans realize this, but at least when I first took over rheumatology at the VA and JP, primary care was not a part of the Department of Medicine. And then later on it became. I always thought that they were one and the same in a sense, and it was just another department. So it has its own administrative structure. And I know that for the things that I knew more about than what happens when people are dissatisfied, that you can go allegedly to the head of the hospital or the healthcare system to complain. They ask for input. I have not ever seen that follow through or know what happens to those complaints, but I wonder if the commissioner gets involved with that kind of thing.
Rob, I'll throw the question to you. When you have only 15 or 30 minutes max with a physician in the room, how do you get the best out of that rapport, out of that interchange?
I think a lot of that goes back to what Jessica was talking about earlier in the conversation about, being ready to ask the questions that need to be asked, having that notebook with those questions and those comments and concerns that you may have with you and pass them on to the provider. But again, to Arthur's point, 15, 20, 30 minutes is sometimes just not enough. When we get veterans coming to our door and we go through the investigation process to see if they qualify for either Mass General Law Chapter 115, which is a benefits program here in Massachusetts, or to work on their VA claim, sometimes the Veterans Benefit Specialists are sitting with them for an hour, hour and a half, sometimes 2 hours. And there's follow-up appointments as well, because they would need documentation from Social Security or from the VA. So 15 minutes or 30 minutes is not enough. But if you need to maximize that, it goes back to what Jessica said about being ready and prepared to be able to ask those questions. But with that said, sometimes the patient or the veteran don't know what questions to ask or what to say, and then that's when it kicks in that they need more time.
Can they ask for another doctor, another PCP or other, if they're unhappy with their current one?
Me, as a patient myself with the VA system here in Boston,
Yes.
I've been fortunate. I've never had to ask for a doctor. I did have to go to patient advocacy one time, but it wasn't because I didn't have enough time. But it was something totally unrelated. But I think you can. I think if you're not happy with your primary care, you could go in there and request another one. You have to go to the patient advocacy office and get that done.
I see.
Mm-hmm.
I'd like to squeak in one last question before we do just a last minute closing things, which is because I think we've had many questions about this, which is, are there any opinions from the group about stem cell or other regenerative therapies? And does the VA system cover this?
I can give you a little information because that's been tested throughout my life at the Brigham. Chondrocytes, which are the specific cells in cartilage. People have been trying to implant those in injured athletes, who are otherwise have a normal joint, but a divot in their cartilage. And it's been technically challenging, but it's not, as I understand it, ready for prime time, although in certain protocols are still being studied. I don't think any of the orthopods that I work with at the VA are doing that kind of thing. And even at the Brigham, it was always just one or two surgeons who had active protocols who were studying it. So it's not generally available, and it hasn't borne fruit even for others. So.
Yeah, I'll also dovetail on that. We've been doing on the active component, like some platelet-rich plasma injections and things like that. And even then, the literature is hit or miss depending on the joint, right? Some joints like knee do fantastic, other joints not so much. And the downside is, again, not covered by insurance because just the evidence is not there to support its efficacy. There are other injectables, biologics, things like that. There are other things like hyaluronic acid, right? Other type of injectables that are covered by insurance that are options. I will say that like any medication, an injectable is never to be used in isolation for optimum benefit. That should always be used with all your other therapies and, other treatments that we talked about in this webinar. So definitely an option, especially if you feel like you've hit a wall with therapies. That could be something to talk to your primary care about as an adjunct, but definitely not in isolation. You wouldn't get an injection and then all of a sudden feel better and go about your business. But it certainly won't last long, and it wouldn't be worth it without kind of the supplemental therapies.
Great. Arthur, did you want to say something and I interrupted you, or did I?
No, I can't speak to stem cells.
I didn't think so, but I thought that perhaps if I cut you off by mistake. Okay. I have about a minute and a half of something to say just towards the end here. And there are a slew of other questions we did not get to, but we will pass those along. Again, we'll try to do our best to wrap them up. Also, I see that Robin put in the chat that I know people were having a hard time copying and pasting some of Arthur's amazing links, but if you are having any trouble, you can email her directly. She put her email in the chat. And if there are any questions, again, she's put it in chat again. You can email her directly and she will send you that information. All you have to do is connect with her directly and she'll be happy to pass those fantastic resources along. I want to thank everybody again, Dr. Liang, Dr. Orth, Arthur Madure. I want to thank Commissioner Santiago. Everyone was tremendous tonight, and this was such a labor of love, but really something that Commissioner Santiago and I have wanted to do for a while now. I think we're going to probably be doing many of these in the coming years. So we want to thank you all for joining us. We also want to bring your attention to our arthritis.org/military website, which is specific to just our military and veteran services communities. Arthritis, our military and veteran services connect group, which has started and is virtual and can be utilized by anyone and everybody all over the country. We have upcoming connect group sessions that will focus on pain management and also with dealing with emotional and mental health issues. We have upcoming webinars for September, which is Pain Awareness Month, on protecting our joints and injury. You can see all these listed here. And again, you can find all of these items, including our podcast and our helpline and our insights assessment survey, all of these things on the website that we just mentioned, which is the arthritis.org/military website. Also, we will be sending out a post-event survey. So I would remind everybody again, like I did at the top of the event, to please take a moment and fill out the survey, because I know Rob teased at the top of the hour that we do plan on doing the next webinar on the connection with pain and mental health. But we definitely want to hear from you on what you're interested in next. Again, thank you all so much for taking some time this Thursday evening to share your night with us. And we just so appreciate your time and energy. Thank you all. Have a great rest of your night. And we appreciate you so much. Take care.